Hi, everyone. I'm Emily.
And this is Eva.
And you're listening to Speech Talk.
We're your research book club so you can do evidence-based practice in practice.
So let's start talking.
All right. We're talking about hearing loss and dementia this week.
Ugh, woof. I feel like the amount that I'm actually yelling at work is ridiculous. I'll go into someone's room and automatically my voice is raised. Like if I see that they are 80 plus, I'm yelling. And then my patients are like, you don't have to yell. And I'm like, oh, sorry.
Yeah, man. Sometimes the carryover between rooms is rough. Like you do have to shout for 3 rooms and then you go in and you are still shouting and the person's like, I can hear fine. Could you maybe not be so aggressive?
And you start whispering. It's
Yeah.
okay.
Yeah.
But I think this is just speaks to how prevalent the hearing loss is in our skilled nursing environment. We're always screaming because they can't hear us. And God forbid they actually have hearing aids. Like that's always my first question. Where are your hearing aids? I don't have them. I don't need them. Just like, great.
They're still at the hospital. They don't work, but they're in my pocket.
Yeah.
Like all those answers.
So we had a few articles that we wanted to review this week. We first wanted to look at, does hearing loss contribute causally to dementia?
Which it turns out a lot of other people wanted to know too.
This was a harder topic than we had originally anticipated, and we had to get through a few different articles to feel like we really had a presentable answer to share with you. So we started off with...
There's an article called Hearing Loss and Incident Dementia by Frank Lin et al., which looked at what they called all-cause dementia, or incidence of dementia regardless of a specific cause. And this is an important caveat because the researchers can't prove that what is causing a patient's dementia. They can only assess it and determine whether or not it's getting worse.
Right. So they followed these participants over 12 years, and they found that, I quote, the risk of incident all-cause dementia increased log linearly with severity of baseline hearing loss, which is to say, if your hearing loss got worse, your cognition declined as well.
Even though the research says that they can't prove that hearing loss causes cognitive impairment, the research does show that they evolve together. So when one gets worse, the other one does.
Right. So then we looked at some informational pages from Johns Hopkins about hearing aids and hearing loss, and they highlighted some quotes from Dr. Lin, one of which we wanted to share with you. Again, I quote, hearing loss contributes to social isolation. You may not want to be with people as much, and when you are, you may not want to engage in conversation as much. These factors may contribute to dementia.
I really like this quote because it shows how changes in hearing status can indirectly affect cognition. So, if you are retreating into yourself because you're not engaging socially, that contributes to cognitive decline. We know that for our patients with dementia, engaging with other people, doing social interactions is really important for maintaining current function. And I personally know that I have seen some crazy changes in my cog patients when they're in isolation. I had this guy who had cognitive problems and had hearing loss. And I had to go in full PPE because he was on ISO. So I've got the mask, then the face shield, and I'm like gowned up in yellow. And we are going 12 rounds over the PCAT short form as his cognitive assessment. And at the very end, when some of the questions are, now, was the woman in the story's name Carol, Mary, or Sue? He's like, why are you calling me Sue? And I was like, I'm not. And it makes me think what you think, like, what have you thought of this whole experience? If you think I'm just like calling you women's names, like that's what you took away. And then it turns out he did have had like what looked like hearing aids in. And I was like, oh, do you use hearing aids? Can I check them? And because that's me shouting. And he was like, they're not hearing aids. I'm listening to the radio. I was like, what is why are you listening to the radio while I'm talking to you? So
Oh my God, that's so funny.
That was a tough assessment.
Have you ever done the like this is my naughty trick, but I'll like take a deep breath in through my mask and then pull my mask down and shout and then pull my mask straight back up because like I cannot do. They're like, I need to read your lips, and I'm like, I'm following precautions. Like
I'm not gonna breathe in your germs. I'm only gonna shout my own breath at my mask.
this is a one-way street. You have mine. I don't have yours.
Yeah. Yeah.
But I also like that the researcher points out important avenues for future research in order to more deeply understand the relationship between hearing and cognition. So, whether
Mm,
we can use hearing loss as a marker for early stage dementia or if we can actually modify hearing to affect dementia risk factors, that definitely needs more research. Through some of these research articles that we went through, they also talked about different types of dementia. And I
mm,
don't want to go too deeply into that, but that's another area where research was like, we can't really say because there's different types of hearing loss versus different types of dementia. And there's like just so many avenues that people are able to go through to say like one causes the other, but like one, I mean, do you have Lewy body dementia? You have a conductive hearing loss, a sensory neural hearing loss. So there's
mm.
just so many different avenues. So that's one of the reasons it was so hard for these researchers to say one can cause the other.
Yeah, that's a really good point. A lot of times we're just grouping the question as does hearing loss cause dementia? But it's like which type of hearing loss and which type of dementia? And all of a sudden there's like 12 different variables you could be analyzing.
Right. But we wanted to look at another study. So we're looking at these risk factors, and one study did try to figure some of that out.
Yeah. So in walks the ACHIEVE study. Get ready for an acronym. ACHIEVE stands for the Aging and Cognitive Health Evaluation in Elders, or the ACHIEVE study. It was a multi center randomized trial to determine if treating hearing loss in older adults reduces the loss of thinking and memory abilities, or cognitive decline, that can occur with aging.
Their findings were pretty spectacular. Their findings state that, and I quote,
You're
I don't
quoting
know
a
how
lot
we
this
did this, but
episode,
I
Emily.
have all the quotes and I stumble on all the quotes. But I quote, in older adults at increased risk for cognitive decline, hearing intervention slowed down loss of thinking and memory abilities by 48% over 3 years.
That's pretty close to a 50% slowed rate over 3 years. That's
Yeah, that is
pretty
significant.
incredible. So they do know, however, that this isn't just for all cognitive decline. This was most effective for people who had a fast rate of cognitive decline. So it was harder for them to assess for people with better cognition the effectiveness of hearing interventions. And that is partially because the study was done over 3 years. So for folks with slow cognitive changes, the potential intervention effects may not have showed up in time.
So, what does this mean for us? More clinical questions, obviously.
Emily, more clinical questions. So we can't for sure say that hearing loss can cause dementia or cognitive impairment, but we can like really, really comfortably state and hopefully emphatically that there is a correlation and that this is an area that needs more attention.
So, we just have this chicken and egg thing going on. It's important to consider these trends when making recommendations for our patients.
So, how can we help out our nursing home residents?
Advocate for hearing screenings regularly.
Yeah, it's a big one. We might be the first people to see a hearing impairment because of our knowledge and how speech relates to hearing frequencies.
That's actually exactly how I caught a hearing issue for my own kid. He when he first started talking, he would lose all of his high frequency sounds. He was only speaking in voice phonemes, and I immediately ran to an audiologist. I said, "What's happening? Where are his high frequency sounds?" So I was able to get tubes in his ears. But if it wasn't for my knowledge as a speech therapist, that's something that I wouldn't have caught. So we do have knowledge on how hearing loss relates to our speech output and what we end up saying and what we end up
Yeah.
hearing. Maybe some of the, you notice people are missing certain sounds or certain parts of the words that aren't in a like class. That's something that only us would know.
And in particular for our older patients, we start to see that elevation in volume, that they're not just asking us to speak up, but they are speaking quite loudly themselves because they're trying to adjust to the fact that they can't hear themselves. So, on that note, continuing to advocate for hearing interventions to keep our patients socially involved will also help with overall quality of life in the long run. Preventing social isolation due to hearing loss is really big here, and we want people to stay involved and active in their day.
And we can help advise our colleagues and patient families on the relationship and the difference between hearing loss and cognitive impairment.
Yeah, I've definitely had patients who presented as cognitively impaired, but really were just hard of hearing. And same with the other way around. Like, people are like, "Oh, you just really have to speak loudly at him." And I'm like, "No, he has early onset dementia. Like, he doesn't understand what you're saying." Or the other way around, they're like, "Oh, he's so confused. Like, you can't really ask him anything." And it's like, "No, actually, he just can't hear you. When you put in his hearing aids or you speak slowly and clearly, he does so much better." Or just try writing.
Yeah. And I've had disagreements in this too with colleagues, like respectful disagreements, but one person, this person has a lot of different issues, right? Like hearing impairment, more severe dementia, but also some psych things going on. And me and this, one of my coworkers are just going back and forth, like, I think that they would really benefit from some hearing intervention so that they can more easily communicate. And they're like, no, they are really stuck in their head. If you give them more sounds, it'll kind of trigger them. So it's important to advocate like both ways and try some things out. Like if you feel like maybe a hearing intervention would be helpful, get a regular amplifier. Have no reason to spend thousands of dollars on hearing aids. Let's try an amplifier. Maybe they'll lose it. Maybe it'll help. Maybe it will drive them crazy. We can only test and see.
Oh man, dude, I had a patient come in and I had never seen them before. They're called pocket talkers. It's just like a pocket sized amplifier. It looks kind of like you're holding a cassette player with uh, headphones, and the hospitals will sometimes give them out.
Mhm.
And so you talk into what looks like the cassette player and it pipes into the headphones. I'm like, obviously, I sound like a technology expert here. Um, but he was so hard of hearing. I had I like eventually couldn't I just realized I couldn't treat this guy because I was shouting into the amplifier and he would just look at me and go, "Huh?" I was like, "Do you have difficulty chewing?" And he's like, "Mm-hmm. Yeah." I was like, "Did you eat the sandwich? My daughter's coming." It was just a completely disjointed conversation, and I was like, I don't know what to do. I don't know what to do." And it turns out writing writing was fine. Like, I don't know why it took me, like, 4 sessions before I tried writing. I felt like such a dumb because the man can read fine.
That's always something that I'm like back and forth on trying because you never know like where their cognitive status has taken them, like, or where their cognitive baseline is. Can they read or write themselves? But I had one person where that worked really well, and I was like, this was frustrating for me because this person could read and write perfectly fine. They were like almost completely deaf. So I had the facility. I said, this person needs a whiteboard and a dry erase marker. And they're like, well, that counts as office supplies. So you have to buy that. I was like,
No.
no, this is a receptive language device at this point. Buy the man a whiteboard. Why are we going back and forth about $5? Like, but he needs this. Or go do a billion pieces of paper and kill trees. I don't know. This is obnoxious.
Yeah, well, and, that's a great zoom out moment because when you think about people's quality of care in their, skilled nursing facilities, if nursing staff can't carry around, like, sheafs of paper for a patient to communicate with them, then what ends up happening is people start just, getting their meds administered to them. They just start doing things for the patients, like changing their clothes, doing whatever it is that nursing does, which are all very important, but the patient doesn't really have as much context for it. It just feels like people are just coming in, shoving things in their face, grabbing their clothes. There's no communication around it, which is just kind of a rough and disorienting process. Um, and I can only imagine what they are taking in for their, how they're perceiving their medical advice from their doctors. You're going into an office, someone is telling you really important information, and you just have no idea.
Yeah, and how are you
That's,
supposed to get actually resident consent to do all of these things and buy-in and avoid that agitation and make sure that they're feeling comfortable if we're just kind of pushing through their hearing impairment and not addressing how to properly care for these people?
Vitamin Water Zero Sugar has great taste, zero BS, and obviously zero sugar. For those with zero room in their calendar, zero patience for slow walkers, those who get 0 hours of sleep on a Saturday night, have zero filter, zero given, and zero interest in grabbing a plain, boring water. Grab a delicious Vitamin Water Zero Sugar today.
Does it ever feel like you're a marketing professional just speaking into the void? But with LinkedIn ads, you can know you're reaching the right decision makers, a network of 130 million of them, in fact. You can even target buyers by job title, industry, company, seniority, skills, and did I say job title? See how you can avoid the void and reach the right buyers with LinkedIn ads. Spend $250 on your first campaign and get a free $250 credit for the next one. Get started at linkedin.com/campaign. Terms and conditions apply.
yeah. We recently had a woman who she couldn't do the BIMs, couldn't answer questions about the day, month, year. And she was kind of behaviorally doing some strange stuff. Like you'd go in to talk with her and she'd just pull the sheet up to her nose. And I was like, yeah, man, this woman is, I, you know, I was very concerned about her ability to give consent for things, whether she should be her own POA. And the next time I went to see her, she was up in her chair. She was not in a loud environment, and we had a regular conversation. And I was like, oh my God, this is like night and day. It was so crazy.
Just a little overstimulated.
Yeah, she did still have a little bit of cognitive impairment, but it did not present nearly as bad as it did on evaluation. And it had a lot to do with the interaction of her cognitive status with her severe hearing loss. It was really interesting to see.
So our evidence tells us that, we just have more clinical questions.
But for now, we can say that there is evidence that supports cognitive decline and hearing loss being related, and that maybe these are just patients that we need to keep a closer eye on as they age to ensure that they're still living their highest quality of life.
So speaking of getting devices for patients, I did have one family who was able to get an amplifier for my patient. And it was just they're really reluctant to get it. The thing was $30 and they're like, "Well, we're just worried that it'll end up being lost." And I'm like, "Well, put her name on it." they,
First
we
of all,
could try.
let's label.
Things happen. And wouldn't you know it? The damn thing got lost.
Oh man. Oh my God. No.
Because I was talking with them and I was like, so I haven't seen it. They're like, we left it here. We did that. We wanted her to have it. And I was just like, we'll look for it. I mean, it did never turn up. She went home without it. But it was just one of those things where it's you wish you could have I don't know, maybe done something more, had your recommendation turn out to be something better. But
Yeah.
even though we know that these hearing things are helpful, sometimes the cognition of it and implementing a hearing device for people who may have extra sensory needs, like putting something in their ear or, just keeping track of things, that's just too much for them to handle in the late stages. And that's
Yeah,
That's
yeah.
what
It's
we
like
gotta take on the chin.
I've come up with a really great idea. We're gonna get him amplified. We're gonna see what happens. The only problem is he has no idea where he keeps putting his amplifier. Yeah, which sometimes is on the patient and sometimes I think is on the building. Like I have found hearing aids and dentures in some weird places, and I'm like, who did this? Who did this? Was it the patient or the person making the bed? I don't know.
I know. And that sucks too, because it's like we can't like take responsibility for everything that happens in the facility. And I'll edge that with patients and families too. Like I really think that this would be helpful. And like, are you gonna take responsibility for it if it gets lost? Like, no, I'm not. No,
I see this
straight up,
person
I
for
will
30
not.
minutes a day.
That is not my job to make sure these $7,000 hearing aids don't get lost. I don't know what to tell you about that. Maybe you can get like extra insurance on that because that is not that is not I don't have that. I am a lowly speech therapist.
Yeah, that's unfortunate.
Maybe an air tag to help. I don't know. That would only help with the charging unit. I don't know.
I I have this patient who she's no longer actually my patient, but I get tons of evals in her room. It's shared room, 2 beds, and for some reason I have had a string of hard of hearing patients in her room, and she hates it. First of all, she hates my voice. She's made it very clear that I have a grating and horrible voice. And I have to elevate it so that her roommates can understand me when I'm doing my sessions with them. And she will like get on the phone with family members and stuff and be like, this woman keeps coming into my room. She's such an a-hole. Is not respectful and will just like go off on me to somebody else in the room, like on the phone while we're in the room together. And meanwhile, I'm just like really trying to tune that out while I'm focusing on my patient and like appropriately administering evaluations or treatment therapy or whatever it is, while there's just this constant stream of somebody with very good hearing just railing on me. It's very hard to balance, I gotta say.
Oh my God, that's so funny. That reminds me, I had one eval like that. It was two. It was like that double room situation. I had a eval in bed A and B, and I started with the one bed, and I was like, how am I going to do my BCAT? Because I don't want them to get extra answers. So I just try to be quiet, and then I go over to bed B, and they're like, what? And I was like, man, I didn't even have to be quiet. Like
That's so good. That's so good. Yeah. Yeah. And a lot of this makes me think about, auditory comprehension and receptive language. Where is that in the mix for all you researchers out there? Like I have a patient who I'm pretty sure hears perfectly fine. He has terrible auditory comprehension, but at a cognitive level seems fairly intact. So what if it's not the hearing loss or the cognition? What if it's auditory processing or receptive language impairments? Man, someone's got to get in there and sort out all these details.
Eva, I think that's actually you. Like, like you pick up that patient and you decide.
I'm going with auditory processing and cognitive impairment. Yeah, like if you shout at him, I think he'd be like, "Oh, what? Why are you yelling?" So I think the hearing loss, it's not hearing loss,
Here's like very specific auditory comp tasks. You've been listening to Speech Talk.
Thank you, everyone, for coming to listen to our Research Book Club. Until next time, keep learning and leading with research.
If you like this episode and you want to give us some love, please rate us on your favorite podcasting app. Leave a review and tell the world, because as podcasters, our love language is in positive affirmations.
If you have a research topic you want us to cover, or you have episode comments, clinical experience you want to share, or just want to send us some love letters, send us an email at hello@speechtalkpod.com.
If you want even more Speech Talk content, check out our website at speechtalkpod.com, where you can find all of our resources we made for you, copies of articles covered, and Eva's blog following these topics and more.
We're your hosts, Eva Johnson and Emily Brady.
Our editor and engineer is Andrew Sims.
Our music is by Omar Ben-Zvi.
Our executive producers are Aaron Corney, Rob Goldman, and Shanti Brook.
To learn about Speech Talk's program disclaimer and ethics policy, verification and licensing terms, and HIPAA release terms, you can go to speechtalkpod.com/disclaimers.
Speech Talk is a proud member of the Human Content Podcast Network.
Human content.